Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 288 of our pharmacotherapy series, which majors in thrombosis. The first question reads, TEN is a 42-year-old man newly diagnosed with unprovoked deep vein thrombosis. He will be treated as an outpatient with enoxaparin 1.5 mg per kilogram subcutaneously daily and started on Warfarin 5 mg orally daily using average daily dosing initiation. His primary care physician would like him to receive follow-up care in the medical center's pharmacist-managed anticoagulation clinic. What are the benefits of formal anticoagulation management services? One of the keys to successful oral anticoagulant therapy is appropriate outpatient management. In comparison with routine medical care, management of warfarin therapy by anticoagulation clinics is associated with significant reductions in bleeding and thromboembolic complications, with reductions in the rates of warfarin-related hospital admissions and emergency department visits, and with outcome-based cost savings for healthcare organizations. Pharmacist-managed anticoagulation clinics offer many benefits for the management of anticoagulation therapy, including improved dosing regulation, continuous patient education, early identification of risk factors for adverse events, and timely intervention to avoid or minimize complications. TEN's referral to a pharmacist-managed anticoagulation clinic is likely to improve his overall satisfaction with care and to improve his clinical outcomes. The availability of portable INR self-testing devices also allows the option of anticoagulation monitoring in the home setting. Patient self-testing of INRs has been shown to result in comparable outcomes to high-quality anticoagulation delivered via anticoagulation clinics. For patients that may prefer this monitoring method, a structured education and follow-up program should be designed and integrated with the patient's provider or the anticoagulation management service. The next question reads, at his initial visit to the anticoagulation clinic, TEN will receive extensive education about his warfarin therapy. What information should be conveyed to him by his anticoagulation provider to ensure the safety and efficacy of warfarin therapy? Successful warfarin therapy depends on the active participation of knowledgeable patients. The anticoagulant effect of warfarin is influenced by various factors, and fluctuations in the intensity of the anticoagulant effect of warfarin can increase the risk of both hemorrhagic complications and recurrent thromboembolism. Pharmacists and other providers can improve adherence to the medication schedule, as well as ensure the safety and efficacy of warfarin therapy, by providing appropriate education to patients treated with this agent. This information may be conveyed through written teaching materials, recorded instruction, individual or group discussion, or a combination of these approaches. Many useful educational tools are available from the manufacturers of the oral anticoagulants and from other non-commercial sources. TEN should receive extensive education about warfarin therapy in an individual teaching session or an organized education program. A wallet card, medical bracelet, or alternative method of identifying him as a patient treated with warfarin should be provided. The healthcare provider who assumes responsibility for his outpatient warfarin therapy will need to provide continuing reinforcement of the essential elements of medication information at each follow-up visit. The next question reads, after receiving 6 days of enoxaparin therapy and 6 doses of warfarin 5 mg per day orally, TEN's INR is 2.4. Enoxaparin is discontinued and TEN is instructed to continue his current dosage of warfarin. He is scheduled to return to the anticoagulation clinic in 1 week for re-evaluation. At that time, his INR is 1.7. So my question to you is, what factors might account for this change in the intensity of anticoagulation? Patients should always be questioned about their understanding of the prescribed dose and their adherence to the prescribed regimen. Questions might include, what dose of the medication have you been taking? What time of the day do you take your medication, and how many times in the last week did you miss a dose of your medication? If there is no evidence of misunderstanding of the correct dose or of noncompliance, numerous other factors should be considered that are known to influence warfarin dosing requirements in individual patients during both initiation and maintenance phases of therapy. Changes in dietary vitamin K intake, underlying disease states and clinical condition, alcohol ingestion, genetic factors, and concurrent medications can significantly change the intensity of therapy, resulting in the need for dosing adjustments to maintain the INR within the therapeutic range. In a dosing cohort of 1,015 patients on warfarin therapy, body surface area, age, target INR, amiodarone use, smoker status, race, current thrombosis, VKORC1 polymorphism 1639 or 3673 GA, CYP2C9*3, and CYP2C9*2 were all independent predictors of warfarin therapeutic dose. Let's look at dietary vitamin K intake. The two primary sources of vitamin K in humans are the biosynthesis of vitamin K2, that is menaquinone, by intestinal bacteria, and dietary intake of vitamin K1, that is phytonadione. The U.S. recommended daily allowance for vitamin K is 70 to 140 micrograms per day, and the typical Western diet provides approximately 300 to 500 micrograms per day. Vitamin K is found in high concentrations in certain foods, including green leafy vegetables, such as asparagus, broccoli, Brussels sprouts, cabbage, cauliflower, collard greens, endive, kale, lettuce, parsley, spinach, and turnip greens, soy milk, certain oils, certain nutritional supplements, and multiple vitamin products. Variations in vitamin K intake have been linked to INR fluctuations in patients taking warfarin. In addition, diets high in vitamin K content have been associated with acquired warfarin resistance, defined as excessive warfarin dosing requirements to reach a therapeutic INR range. Numerous cases have also been reported in which patients previously stabilized with warfarin experienced elevations in INR with or without hemorrhagic complications when dietary sources of vitamin K were eliminated. Conversely, reductions in INR with or without thromboembolic complications have been reported in patients in whom dietary sources of vitamin K have been added. This data illustrate the potential clinical significance of dietary changes in patients taking warfarin. To minimize these potential effects, TEN should be counseled to maintain a consistent intake of dietary vitamin K. His final warfarin maintenance dose will be partially influenced by his typical diet. However, restriction of dietary vitamin K intake is unnecessary, except in cases of significant resistance to the anticoagulant effect of warfarin. TEN should be aware of the types of foods and supplements that contain large quantities of vitamin K, and should be counseled to maintain a consistent diet, to avoid binging with foods high in vitamin K content, and to report significant dietary changes to his healthcare provider. Appropriate assessment and follow-up are essential to prevent hemorrhagic or thromboembolic complications that may arise from changes in INR resulting from dietary alterations. Next we will look at underlying disease states and clinical conditions. The presence or exacerbation of various medical conditions can also influence anticoagulation status. Diarrhea-associated alterations in intestinal flora can reduce vitamin K absorption, resulting in elevations in INR. Fever enhances the catabolism of clotting factors and can increase INR. Heart failure, hepatic congestion, and liver disease can also cause significant elevations in INR because of a reduction in warfarin metabolism. End-stage renal disease is associated with decreased CYP2C9 activity, resulting in lower warfarin dose requirements. The impact of changes in thyroid function on warfarin dose requirements is controversial. It has been suggested that levothyroxine initiation accelerates clotting factor catabolism, enhancing warfarin's anticoagulation effect. However, there is conflicting evidence in whether a warfarin-levothyroxine interaction has an impact on the INR. A recent retrospective review did not show a difference in the mean warfarin dose to INR ratios before and after levothyroxine initiation, suggesting that no clinical interaction exists, and additional monitoring may not be necessary. Acute physical or psychologic stress has been reported to increase INR. Increased physical activity has also been reported to increase the warfarin dosing requirement. Smoking can induce CYP1A2, which may increase warfarin metabolism in certain patients, resulting in increased dose requirements. Due to its high vitamin K content, chewing smokeless tobacco can suppress the INR response. Thorough education of patients taking warfarin should include detailed attention to recognizing the signs and symptoms of changes in underlying disease states and clinical conditions that can influence warfarin dosing requirements. They should be instructed to contact their anticoagulation management program whenever changes occur that might influence INR and warfarin dose requirement. Let's briefly talk about alcohol ingestion. Chronic alcohol ingestion has been associated with induction of the hepatic enzyme systems that metabolize warfarin. Therefore, warfarin dosing requirements are sometimes higher in alcoholic patients. Conversely, acute ingestion of large amounts of alcohol can slow warfarin metabolism through competitive inhibition of metabolizing enzymes, leading to elevations in INR and an increased risk of bleeding complications. Despite some reports linking low amounts of alcohol to an elevated INR, in general it is believed that moderate intake of alcoholic beverages is not associated with alterations in the metabolism or the therapeutic effect of warfarin as measured by INR. Patients taking warfarin should be educated to limit their alcohol consumption to less than 1 to 2 alcoholic beverages per day. Chronic drinkers should be counseled to limit the drinking and maintain a regular pattern to avoid fluctuations in INR. TEN does not need to abstain from drinking alcoholic beverages in moderation, but he should be counseled to avoid the sporadic ingestion of large amounts of alcohol. Conversely, alcoholic liver disease, i.e., cirrhosis, can alter multiple hemostatic mechanisms and reduces production of hepatic clotting factors. Decreased production and clearance of vitamin K-dependent clotting factors account for the prolonged prothrombin time and INR often seen in these patients. Therefore, an increased response to warfarin would be expected in patients with liver impairment. Worsening liver function is also a predictor for bleeding complications, and patients with end-stage liver disease are at increased risk of bleeding. Before instituting warfarin therapy in these patients, the risks of bleeding associated with both the underlying liver disease and warfarin therapy must be weighed against the benefit of preventing thromboembolic events. If warfarin is indicated, the best approach would be to use a cautious initiation and dose titration approach by starting with lower doses and titrating up slowly to goal. Small increases in dosage should be made, if indicated, recognizing that the full effect of any dose adjustment may be delayed in patients with severe liver dysfunction. Monitoring for bleeding complications is essential, even at goal INR ranges, when warfarin is used in patients with liver dysfunction. We will now look at genetic factors. The cytochrome P450, CYP2C9 and vitamin K epoxide reductase complex 1, abbreviated as VKORC1, genotypes have been associated with warfarin dose requirements, and dosing algorithms incorporating genetic and clinical information have been shown to be predictive of stable warfarin dose. However, dosing algorithms that incorporate CYP2C9 genotype and vitamin K epoxide reductase complex 1 (VKORC1) haplotype along with other patient characteristics to predict warfarin maintenance doses showed mixed results in randomized, prospective clinical trials, questioning the utility of this approach. Based on current data failing to show a benefit, ACCP recommends against the routine use of pharmacogenetic testing for guiding doses of vitamin K antagonists. This is a Grade 1B recommendation. Further research is needed to determine the place of warfarin pharmacogenetic testing. The next question reads, how should TEN be assessed and evaluated at this clinic appointment? At each clinic visit, TEN should be assessed for signs and symptoms of bleeding, and for signs and symptoms of clot progression and/or recurrence. The accuracy and reliability of the INR test should be also considered. Additionally, TEN should be asked about missed or extra doses of warfarin, dietary changes, such as increases or decreases in vitamin K, and alcohol use, medication changes, recent illnesses, such as nausea, vomiting, fever, chills, or diarrhea, any recent falls, and any known upcoming procedures. Regardless of the INR result, all factors that may influence TEN's anticoagulation status should be evaluated carefully. The next question reads, after a thorough assessment, it is determined that TEN has adhered to his prescribed warfarin dosage schedule and that there is no apparent explanation to account for his reduction in INR. How should his warfarin dosage be adjusted? When over-anticoagulation or under-anticoagulation is verified, an adjustment in warfarin dosing may be necessary. Typically, dosing adjustments of 5% to 20% of the total daily dose, or the total weekly dose, are appropriate to reach the therapeutic range. Because warfarin does not follow linear kinetics, small adjustments in dose can lead to large INR changes, and thus large dose adjustments, i.e., greater than a 20% increase or decrease of the total weekly dose, are not recommended. These maintenance dosing guidelines should only be applied to patients who have reached a steady-state dose and not in the initiation phase of therapy. Because TEN is currently taking 5 mg daily, an adjustment of 15% would increase his dosage to approximately 5.5 mg per day. This dosing adjustment can be made by having him take one 5 mg tablet and half of a 1 mg tablet each day, that is same daily dosing, or by having him take 7.5 mg 2 days per week and 5 mg all other days of the week, that is alternate day dosing. Patient preference about breaking tablets in half, the likelihood of confusion about different tablet sizes, and potential confusion on taking different doses on different days of the week should be the primary considerations when selecting a dosing method. The next question reads, TEN agrees to increase his Warfarin dosage to 5.5 mg per day. A new prescription for 1 mg tablets is written for him, and he is instructed about the use of these tablets. When should his INR be reassessed and his anticoagulation status, including physical assessment, be re-evaluated? It will take several days for his INR to reach a new steady state because of the long elimination half-lives of both warfarin and the vitamin K-dependent clotting factors. His INR should be rechecked approximately 1 week after a dosing adjustment has been made. Once a stable dose has been reached, patient assessment and INR monitoring typically occurs every 4 to 6 weeks. However, if TEN displays any signs of medical instability or non-adherence, a follow-up schedule of every 1 to 2 weeks is indicated. For carefully selected patients with well-controlled INRs, recall frequencies out to 12 weeks can be recommended. For patients taking warfarin with previously stable therapeutic INRs who present with a single out-of-range INR of equal to or less than 0.5 below or above therapeutic, continuing the current dose and testing the INR within 1 to 2 weeks is suggested, rather than changing the overall daily dose. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 289.